Hi, I'm Dr. Pamela Morris. I'm here at day 3 of the Women's Health Masterclass in Dana Point, California. And I'm joined today by Dr. Sadia Khan, who is Associate Professor of Medicine and Preventive Medicine at Northwestern University Feinberg School of Medicine. And we're discussing a really challenging topic called Challenges and Advances in the Management of Severe Hypertriglyceridemia. And Dr. Khan, it's interesting. I wonder if you feel the same way I do. Whenever I open my clinic schedule and look at the reasons for referral, one of the ones that causes me to get a little chest discomfort is when it says severe hypertriglyceridemia, because it really is one of the most difficult problems that we manage.
Yeah, I think the challenge is the number of effective therapies that lower triglyceride levels and improve cardiovascular outcomes are very few, if any. And I think the challenge that we have is we know that elevated triglycerides are a marker of cardiovascular disease risk and sometimes can represent residual risk, even if you've gotten that LDL cholesterol as low as you wanted. And we heard some great talks today about how people manage or approach statin and non-statin therapies. You're still left with, how do I get that triglyceride to an optimal level? Not just lower, but to an optimal level.
Right. And it's interesting. Could you talk a little bit about the genetics of severe hypertriglyceridemia? I think many of us are used to thinking about FH as being not uncommonly related to a monogenic disorder. Let's talk a little bit about the genetics of severe hypertriglyceridemia.
We know there are definitely genetic or inherited risk factors related to severe hypertriglyceridemia. But a lot of times we can't find that one gene or a specific variant that really helps us understand, like we do in FH, exactly what's causing elevated levels. There are a lot of secondary causes of hypertriglyceridemia as well. Sometimes thyroid disease or screening for other factors can be helpful and important to make sure that we're addressing if there is a modifiable factor leading to elevated triglycerides. That's more of an acquired factor as well. But oftentimes we're not identifying a specific genetic variant that we know what we can then treat with a therapy for this.
Well, I think that's important because the vast majority of what our viewers will be seeing is that not monogenic, but polygenic hypertriglyceridemia, and oftentimes exacerbated, as you mentioned, by one of those exacerbating factors. In particular, in the context of the cardiometabolic health, it is usually going to be poorly controlled diabetes. Now, when you look at what the first steps are in managing, once you've evaluated for secondary factors, what's the foundation of your approach to a patient with severe hypertriglyceridemia?
I think, like you mentioned, the secondary factors can be really helpful to make sure that you can rule out treatable things like thyroid disease. Then it's approaching the metabolic risk factors, particularly with diabetes. We also have very effective therapies like GLP-1 receptor agonists that not only manage the diabetes, but can also lower the triglyceride levels. We don't talk about it that much for triglyceride lowering since that's not their target, but it is a very happy side effect of GLP-1 receptor agonists, so that can be a really useful approach. The other piece about high triglycerides that I think is really important is using that information as a red flag or a risk marker. So if we think of it as a signal of residual risk that exists, then testing for apolipoprotein B or ApoB as another risk marker can be useful as well. We know that even when someone's on optimal statin therapy and their LDL cholesterol may be at target, if their ApoB is still elevated, that represents still elevated risk that could be then managed or intensified by other non-statin therapies like PCSK9 inhibitor. And so the triglyceride level can be kind of a trigger to look further and better qualify or characterize where someone's risk is.
And I think one of the important things, or at least three of the most important things in managing high triglycerides really is lifestyle, and lifestyle. which I think is critically important. Now, just turning to a minute for pharmacotherapy for hypertriglyceridemia, what's available? What do you use?
Yeah, it's a really challenging question. Fibrates haven't had a great effect in terms of lowering triglycerides a little bit, but not really having good cardiovascular outcome or benefit in the trials that we've seen in terms of outcome trials. Icosapent ethyl is, of course, a therapy that's available that was studied in individuals with high triglycerides over 150 and high cardiovascular disease risk and showed a benefit. But there's some controversy about whether or not the benefit that was observed was because the placebo arm may have had additional risk related to the treatment that they were getting. So I'm a little hesitant on icosapent ethyl because we don't yet have clear data that it's definitely beneficial. Now, if you have a patient that has persistently high triglyceride, is at very high cardiovascular disease risk, and you've optimized every other therapy you have, I think it's reasonable to consider it in that situation.
And I think one of the things that's also important is remembering the role of statins. You know, we have two goals in hypertriglyceridemia. Most importantly, in severe, is to reduce the risk of pancreatitis. But second of all, many of these people are also subsequently at risk of cardiovascular disease. So we also need to remember the role of statins. You know, there's a lot on the horizon for high triglycerides. Can you talk about some of the therapies that are in development?
There's a lot of exciting new therapies that are out there that are trying to look at different pathways that can lower triglycerides. And I think your point about what the targets are really critical to that, because any therapy that's being evaluated for lowering triglycerides, we kind of have two things that we're looking at beyond whether or not they lower triglycerides is do they actually change the risk of pancreatitis, which of course is the immediate short-term life-threatening complication, and then do they change cardiovascular disease risk? I'm often reminded of the story around HDL cholesterol lowering whenever we're talking about triglycerides, because how you lower triglycerides probably matters a lot in terms of whether or not we're going to see benefit for the pancreatitis risk and cardiovascular disease risk. So I think those continue to be the anchors that we need to focus on when we think about new therapies that are emerging.
And I think most of the therapies now are really focusing on those regulators of lipoprotein lipase, the ANGPTL3 and the ApoC3. And really that data is maturing. And we've had some great science that in early clinical trials that is looking exciting. Well, thank you so much for being here today with us here at day 3 of the Women's Health Masterclass.
Thank you.